Hello, my name is Jacob Laubach. I'm an instructor at the Dana-Farber Cancer Institute in Boston, Massachusetts. I'm here at the 2013 ASH meeting discussing our study Quantifying the Risk of Heart Failure Associated with Proteasome Inhibition, a retrospective analysis of heart failure reported in Phase 2 and Phase 3 studies of bortezomib in multiple myeloma. The premise for our study is that outcomes for patients with multiple myeloma have improved dramatically over the past 10 to 15 years as a result of pharmacologic developments in the field. Various pharmacologic agents used in the treatment of multiple myeloma are associated with cardiac toxicity, including anthracyclines, high-dose therapy, as well as proteasome inhibitors. And in fact, both bortezomib and the more recently FDA-approved proteasome inhibitor carfilzomib carry cardiac toxicity in their respective FDA labels. In this particular study, we reviewed cardiac events, specifically grade 3 or higher heart failure events that were observed in Phase 2 and Phase 3 clinical trials of bortezomib in patients who had newly diagnosed disease as well as relapsed and refractory disease. It's important to note that patients with multiple myeloma are at high risk of cardiac events as a result of advanced age, as well as the fact that many patients have a prior history of cardiovascular disease. We were interested in determining whether or not treatment with bortezomib led to an increased rate of grade 3 or higher incidence of heart failure. So what we did was we looked at Phase 2 and Phase 3 clinical trials in the relapsed refractory setting as well as the newly diagnosed setting. In the relapsed and refractory setting, we looked at 4 different clinical trials, and in the upfront setting, we looked at both the VISTAS trial, which was a comparison of bortezomib, melphalan, and prednisone to melphalan and prednisone as well as a pooled analysis of 3 different clinical trials that were performed in patients with newly diagnosed multiple myeloma. In both the relapse setting and in the upfront setting, we observed that there was no significant increase in the rate of grade 3 rates of heart failure in both newly diagnosed and relapsed and refractory disease. Specifically, in looking at comparative trials wherein a bortezomib-containing regimen was compared to a non-bortezomib-containing regimen, the overall rate of grade 3 or higher heart failure was essentially equivalent, at 2.2% in patients who received bortezomib as part of their chemotherapy and 1.7% among those who did not receive bortezomib. In conclusion, there does not appear to be an increased risk of grade 3 or higher heart failure events among patients who receive bortezomib in comparison to those who did not receive bortezomib.